Good evening, everybody. Welcome to lecture number one for the year. This is our National Fellow Online Lecture Series. My name's Craig Pille. I'm one of the members of the committee that helps to organize these lectures throughout the year. Just want to go through some housekeeping things before we get to the meat and potatoes of our lecture with Dr. Berkowitz here today. Before we get started with that, just want to mention that this is our National Online AMSSM Fellows Lecture Series. It's an adjunct to your home program, fellowships, educational content. Our goals are to make sure that we're providing you with direct access to educational experiences across AMSSM, and at times even inviting some guest experts. We happen to have two birds, one stone sort of situation here today with Dr. Berkowitz. And this is a primary goal to assist in the CAQ exam preparation for the end of the year. Just some housekeeping rules. Make sure devices, microphones are muted. Turn off your video. This will actually help us kind of transmit the lecture a little bit more smoothly on our end. Feel free to submit any questions through the chat function, and I'll field those as they come in and try to get them answered by the end of the lecture. And we'll have a Q&A session at the end and even some CAQ practice questions if we've got the time to do it. And then there is an evaluation at the end of the lecture. We would love to have your input. There is a web link found on amsssm.org, clicking on the education tab and then selecting fellow online lecture series. You're able to go through a little review there of the lecture and provide any feedback on this lecture and any future directions you'd like to see this lecture series go. There's also a QR code which we can circulate as well if necessary. And then one more shameless plug here for another content kind of dump from AMSSM. We have the Library of Sports Ultrasound Pathology, which we are continuing to augment and expand. Collection of ultrasound pathologies from upper extremity, lower extremity, and everything in between. Any attending or trainee can submit cases with high quality images for that library to continue its expansion. And cases are published on the AMSSM website. So great opportunity to add some sports ultrasound publication kind of vibe and feel to your CV. And without further ado, I want to introduce Joshua Berkowitz. He is a nationally recognized expert in sports hematology and has particular interest in managing athletes with blood clotting problems. He cooperates a specialty clinic at the University of North Carolina committed to managing professional, collegiate, and other high-level athletes who have developed blood clots. He's an associate professor of orthopedic surgery, internal medicine, and pediatrics at the UNC School of Medicine, where he's also serving as chief of the non-operative sports and musculoskeletal medicine division. He serves as a team physician for UNC Chapel Hill, USA Lacrosse, Chapel Hill High School, and two professional ultimate frisbee teams, the Carolina Flyers and the Raleigh Radiants. And he's a member of the medical advisory group for both USA Ultimate and an event physician for the NBA. We feel very fortunate to have Dr. Berkowitz here with us today to share his knowledge and his expertise on sports hematology, which I think is a really great start to our year. Dr. Berkowitz, take it away.
Greg, thanks. I appreciate it. Always great to talk to this group. I found out just a minute ago that this is the first lecture of the year, so it's a very classic set the bar low and things will improve for you guys in this lecture series throughout the course of the year. So well played, Craig. So yeah, I think without further ado, we'll jump in. Just a few disclosures to make. Now this is how, of course, the corporate world does disclosures. This is actually the full text of the Apple software agreement. So probably 80% of people on this call have agreed to this without reading it. I actually have no financial relationships to disclose. I do always like to disclose, however, that I am not a hematologist. Probably worth throwing that out there. I do know a few, Dr. Stefan Moll, close colleague of mine here, who I've been working with in sort of a niche space around sports and hematology for about a decade now. Not that I'm old, it's just been that long. And then Dr. Scott Berkowitz is my dad. I've known him for even longer. And so whatever you get genetically about hematology is probably attributable to him. So the field of hematology covers a lot of territory. You can do a whole fellowship in that. Sports hematology, frankly, is not really even a thing. But I think what we're trying to do is sort of delineate what elements of hematology are perhaps most relevant to the sports medicine physician, and kind of distill that out. So what I'm hoping to do in the next 40-ish minutes, 45 maybe, is sort of relevant to sports medicine, cover some of these topics that again are important for sports physicians to know, and some of these are potentially high yield for CAQ. So we'll start talking about sickle cell traits. You know, very basic stuff. Red blood cells contain hemoglobin, which binds oxygen for transport through the body. As I'm sure you remember, because this is scintillating stuff, each hemoglobin protein has four subunits, two alpha chains, two beta chains. When we talk sickle cell trait or sickle cell disease, we're talking about a single nucleotide polymorphism in a beta chain of hemoglobin, causing this hemoglobin S variant. So the most common hemoglobin genotype would be hemoglobin A. And this SNP is what accounts for either sickle cell trait genotype, which is one hemoglobin A, one hemoglobin S gene, or sickle cell disease genotype, hemoglobin S disease. Suffice it to say, sickle cell disease is a very serious illness. You guys are all physicians, you guys know this, and I guess probably most relevant to sports medicine, it's just generally incompatible with athletic participation. That doesn't mean people with sickle cell disease can't participate in any physical activity, but just when you're talking about higher levels of athletic participation, just this disease tends to be too debilitating. We don't really encounter that in high level athletes. However, almost on the very opposite end of the spectrum is sickle cell trait. Some people even consider this an asymptomatic carrier state. I certainly wouldn't consider it a disease state. It may be a little more than an asymptomatic carrier state, but generally speaking, people do very well with this. Anyone born in the US in the past 20 years has had sickle cell testing on their newborn screen. I think South Dakota was the last state to come on board in 2005. But so all 50 states, DC, US Virgin Islands, Puerto Rico, everyone screens for sickle cell trait on the newborn screen. Now, specific individuals are often not aware of their status, whether it wasn't communicated or it was communicated, but basically was said like, hey, your child has sickle cell trait, but don't worry about it. It's not a big deal. So it was disregarded. A lot of people don't have this information, but again, if you take care of college athletes, sadly enough, they were all born after 2006 now, or at least the new incoming ones. So that information is out there somewhere. And this is very common. The incidence in the US, based on 2010 data from the CDC, is at 1.6% of all births for individuals with sickle cell trait. In the Black population, 7.3%. That's obviously very high. But even in the white population, 0.3%. That's 3 out of every 1,000. We have 800 student athletes, like give or take, on campus here. And so if you're talking about something that occurs even, at a 1 in 300 rate, 1 in 350 maybe, in the white population, we probably have 350 Caucasian athletes on campus, right? So it's not so rare that you won't see it in other populations. I said on the prior side, some people just call this an asymptomatic carrier state. Well, it's important to note in the sports world that there is literature linking sickle cell trait to exercise-related complications, the most important of which, of course, being sudden death. The data on this is mixed. It's a little bit controversial, but there are some large and well-done studies that estimate something on the order of a 30-fold increased risk of exercise-associated sudden death. And while the data, again, is not entirely clear, some studies would contradict this. I think if there's even a question that there's potentially a 30-fold increased risk of death, it's at least something that we need to be aware of, cautious about, pay close attention to, obviously study more. Less controversially linked, exertional rhabdo, splenic infarction, several sort of renal dysfunction states. It seems to be linked again with variable consistency and some contradictory literature to training intensity, dehydration, heat, and altitude are commonly cited. Again, the literature is not abundantly clear on all of that, but when you consider, cells that sickle, they tend to do so when releasing oxygen, and a lot of the issues associated with sickle cell disease, certainly, and red cell sickling in general, relate to increased blood viscosity. Again, these associations at least make intuitive sense and are worthy of consideration. The NCAA, the Armed Forces, mandate sickle cell testing. Again, being sickle cell trait positive doesn't preclude you from participation in either group. And the Sports Medicine Handbook, if you guys are not aware of this, is actually a pretty good resource for anybody who takes care of collegiate student athletes through the NCAA, has some best practices that are delineated. Um, I think the big thing to discuss here is ECAST, exercise collapse associated with sickle cell trait. Worth knowing about because it's potentially catastrophic, i.e., people can die. And the presentation, of course, can vary. But some of the key features are that, generally speaking, this is associated with not just like a workout, but typically a particularly intense workout, right? Like, someone's trying to make you run hills until you vomit type of workout. Um, Weakness is often a more prominent presenting factor than pain, but pain certainly can occur, and it's most commonly in the legs and low back when it occurs. And then when an individual with ECAST collapses, they're typically conscious at the time of collapse, and that can differentiate it from some other causes. But it can rapidly progress to unconsciousness and to death. We like to avoid that. The associated cardiac arrest is often pulseless electrical activity, which of course is not a shockable rhythm. And so definitely something that we're trying to avoid any case we can. So again, to sort of drive home some of the key elements of ECAST, typically associated with an intense training with unlimited rest periods, right? Just like going to red line and then staying there, staying there, staying there, not allowed to recover or not able to recover or choosing not to recover. Deconditioning may contribute, so this seems to be more common, like in early football training camps or perhaps in early military boot camps. But that's not always a factor. Very well conditioned athletes can still have this issue. Again, muscle weakness is prominent. Pain may be present, but you're not going to have like the rigid muscles that you have, from cramping per se. Temperature should be normal or maybe slightly elevated in the setting of high level exertion. But again, if the temperature is 104, you're not calling it ECAST, right? That's a heat stroke. And then again, this element of consciousness and normal mental status at the time of collapse. If you have a cardiac arrest, when you collapse, you are not conscious, right? So conscious collapse can kind of help give you some clues. So more keys here, and on the right is an algorithm. The citation is below. What the military lacks in graphic design expertise, they make up for in the quality of their algorithms. I find these very useful if you actually go through them specifically. They're actually very well laid out, just not the most visually appealing. So it's really important that you recognize someone when they're struggling, right? So education is an important piece, and that's not just you. At UNC, actually, we do have a physician at every football practice, at least, but certainly not every sport practice. And in most scenarios, right, it's going to be the athletic trainer or even coaches needing to be educated and recognize when someone's having a hard time. If you recognize someone who's struggling, they should cease that activity immediately. This is not a thing you should try to push through. Again, not 100% clear in the literature, but oxygen is likely helpful. And then having the AED at least on hand, like at your side, is appropriate. Some would even argue, like if you have suspicion for ECAST or an impending ECAST, even just putting pads on. And again, a low threshold to transport for further care. I mentioned earlier, these can progress very quickly to a very bad situation. And so, like you on a sideline with an AED and no help is not the ideal situation if things were to get worse. And so, for as much as people often can resist transport, it's probably safest if you have any sense that progression, to a worse state is a possibility. Prevention is, of course, preferred, right? Again, that gets back to the education piece. Coaches, including the strength and conditioning coaching staff, ATs, us, everyone needs to know. Good acclimatization, right? The NCAA actually mandates an acclimatization period. I think the military does something similar. And conditioning best practices, right? It's difficult if you have a head strength coach who's quote unquote old school and just like tries to run people as a form of torture. That is both not the best way to condition an athlete, period, and that can be dangerous. So making sure that the whole medical team and coaching staff is on board with best practices for conditioning in general. Hydration is probably helpful. And again, early recognition, to nip things in the bud. And then preparedness is on us, right? So oxygen needs to be available. We need to make sure that is the case. You don't know when this is going to happen, so you must always have oxygen available when it could happen. Same with the AED. Um, all right, shifting gears, we're going to talk a little bit about anemia. Again, very basics. Anemia is referencing reduced total red blood cell mass. Three things we're going to talk about on the slide here. So athletic pseudoanemia, it's got a few different names, but essentially this is not anemia. This is just a dilutional lab artifact. You remember, like when we're measuring hemoglobin or hematocrit, hemoglobin's a concentration, grams per deciliter. Crit's just a percentage of total blood volume. Um, so essentially both concentrations. Aerobic exercise training leads to an increase in plasma volume. Um, and in red blood cell synthesis, the plasma volume increases. It increases stroke rate, so it can increase cardiac output. So this is a functional adaptation of athletes. The plasma volume expansion tends to outpace the increase in red blood cell mass, and so relatively speaking, more plasma, lower concentration of red blood cells. So when you measure hemoglobin in grams per deciliter, it's going to get diluted out to a degree. So on laboratory evaluation here, you'd see a low hemoglobin or low crit with otherwise normal CBC, like iron studies would be normal, et cetera. It's not really an anemia. Iron deficiency, and again, not specifically talking about iron deficiency anemia here, but iron deficiency is actually quite common. It depends, like, sort of where you set your metric. Ferritin is used to screen on a regular basis, and it is a good screen, but you have to remember that it's a limited measure. Again, the citation for this study is on the bottom there, and I modify the tables just a touch, but the point is, like, this was a systematic review and meta-analysis. It ultimately, captured over 17,000 individuals. And that table one, you can see, if you set your ferritin threshold at 50 or above, then over half of these, college athletes would be iron deficient by that metric. But really, if you set it at 30, then about 30% are, and even if you set it at 20, over 20% are. So I'm very common to have these findings. Table two breaks it down by the sport in which they participate, and you can see there's some variability. But in endurance runners, I'm over a third with a ferritin less than 20. But ferritin doesn't tell the whole story, right? And iron deficiency anemia is actually a very late finding of iron deficiency. So, with the diagram here, just a visual depiction, right? If you have, fully replete iron stores, then everything's great, and all your laboratory parameters should be normal. When you begin to fall in the negative iron balance, right, like you're losing more than you're taking in, iron stores will begin to deplete, and that's where you'll begin to see the ferritin dip. Again, it may not immediately fall below 20, but then you'll get into a place where, like, it's fallen low enough that it's actually difficult to make new red cells, and then to a point where you're in a negative enough state that you actually have anemia. But that's almost an end stage finding of iron deficiency, and that's where you'll get into your classic sort of microcytic hyperchromic anemia. Because of this, a lot of people advocate supplementing, again, for low ferritins, particularly below 20. Again, a little controversial what the threshold is. Do people feel and perform better over 50, and should we supplement up to that target? But I think there's pretty wide agreement that if your ferritin's less than 20, probably some form of supplementation is appropriate. So iron deficiency anemia still is the most common cause of anemia in athletes. And again, it's usually related to one or a combination of inadequate iron intake, blood loss, or sweat losses. So sweat does contain iron. It's a pretty minor contributor in most athletes. But if you have someone, I'm in North Carolina, right? Like, our cross country athletes are running their 80, 85, 90-mile weeks, whatever. And if you have someone who's a heavy sweater in the heat and humidity that we have here, it actually can add up for some athletes. So for most athletes, not a major contributor. But if you're spending 6 hours out of your day sweating heavily, it could be a thing. Again, you'll typically see a microcytic anemia, a low retic, or maybe a normal in the setting of, it should be high, and then, of course, low iron. Dietary modifications sometimes can be enough for mild iron deficiency, although often iron supplementation is recommended, particularly in athletes, to speed the process along. Time's always a factor. When it comes to dietary iron, you'll see charts like this are a dime a dozen. There's a million of them out there, and if you look, those top two rows are meat and seafood sources of iron, and you can see that many of those are very high in iron concentration. But even down below, lots of vegetables and other things that are compatible with vegetarian and even vegan diets that have pretty high concentrations of iron as well. But unfortunately, the story with dietary iron is not as simple as the concentration in the food. Um, this highlights. Um, sort of differential absorption of different foods. Heme iron is something that definitely increases the absorption of dietary iron. It's not the only thing. Vitamin C plays a role. There are lots of things that play a role. But I think this diagram shows well. The pale orange bars are sort of equivalent to what the chart on the left is showing, sort of how much iron is actually in the food. But it's the darker orange bars that's what your body actually absorbs, right? So you could ingest, 3 pounds of iron, but if you don't absorb any of it, then you have, obtained no iron in your diet. Um, and so meat and seafood sources, because you're ingesting the iron with heme iron along with it, tend to be much better absorbed. So even though, 2/3 of the way down, right, 170 grams of tofu has more iron, per serving than the 100 grams of lean beef. The actual absorption, the darker bar, like you'll get much more out of it. So again, that doesn't mean you cannot get adequate iron in your diet through a vegetarian or vegan diet or other restrictions, but just it's not as simple as like, oh, well, if I just eat a bunch of spinach, I'll be fine. Again, if you have access to sports nutrition, sports dietitians, they can be really useful in a number of regards, including this one. Your blood loss, again, I'm not going to give you a lecture about menstrual bleeding or traumatic bleeding, right? If blood is falling out of your patient, then you're probably not acutely worried about anemia. Do bear in mind gastrointestinal bleeding. So a lot of athletes are on NSAIDs. You can certainly have occult gastrointestinal bleeding or more significant gastrointestinal bleeding as a result there. And then also again in this college athlete population where I spend a lot of my time, like that's kind of a prime age for development of things like inflammatory bowel disease, right? So Crohn's disease, ulcerative colitis, etc. And then blood loss through hemolysis can also be a factor. I think again in this sort of quote unquote sports hematology realm, hemolysis is not a huge thing. Again, we're just talking about destruction of red blood cells. It can be intravascular, extravascular, whole big differential diagnosis, most outside the scope of this conversation. But exercise-induced hemolysis is something that will come up. Really, the etiology is not terribly well understood. It was originally described in soldiers and distance runners and often gets called March hematuria or I mean that entity was described first. You'll hear foot strike hemolysis or runner's hemolysis, all these things. It's presumably a mechanical destruction of red cells. Again, in those early descriptions from all the foot strikes of a marching soldier or a distance runner, but it has been seen and documented in other endurance athletes, including swimmers. Right, there's not a lot of striking per se. It seems to correlate with duration and intensity of exercise. So a lot of hypothesis about whether it's shearing of the cells as they go through the vasculature, if it's related to muscle contraction and compression of the vessels, metabolic factors, etc. Um, it's more or less a diagnosis of exclusion, right? If you see someone who's hemolyzing, I would not jump straight to, oh, but they're a runner, so it's fine, right? It needs to be worked up. But oftentimes you will find that workup is unrevealing, and this may be your diagnosis. May present with anemia. Sometimes it's urine discoloration, again, whether that's from hyperbilirubinemia and spilling some bili into the urine, or whether that's actually more of a hemoglobinuria, myoglobinuria situation. The overall anemia is typically mild. It's typically macrocytic, right? These people are able to make enough retics. So it's big red cells and then hemolytic, right? Bili will be up, LDH will be up, haptoglobin will be low. It's notable, that the typical red blood cell lifespan in the general population is usually cited at 120 days, in that ballpark, maybe a little less, 110, something like that. Um, for endurance runners, it's actually much shorter, like even in the ballpark of perhaps 70 days. So, like red blood cell turnover definitely seems to occur more quickly in certain athletic populations. Um, and again, you can get hemoglobinuria, myoglobinuria, probably worth teasing out the difference because if it's hemoglobinuria, maybe related to hemolysis. If it's myoglobinuria, then you may actually be dealing with rhabdo. And exercise-induced hematuria itself can be an entirely separate entity from exercise-induced hemolysis. It's typically benign. Uh, in general, some relative rest, right? Stop with all the foot strikes and the red blood cell shearing, activity modification, maybe equipment modification, changing shoes more often so there's more padding, that type of thing. But conservative management's usually the answer. Um, Opposite of anemia. So this is an elevated red blood cell mass, erythrocytosis. Again, there is such a thing as a pseudo erythrocytosis, and then we'll talk a little bit about doping and whether altitude training is a role here. So a pseudo erythrocytosis, again, this is a temporary contraction of plasma volume, usually due to dehydration. It happens very frequently around here. I'll see a student athlete in clinic and they've come straight from practice because they're always either coming straight from or going straight to practice as they have busy schedules. So if they're fresh off a workout and get a blood draw while they're a little bit dehydrated, then that hemo concentration can certainly result in some aberrant lab values. But I would also suggest that if you identify an athlete with erythrocytosis, it should at least cross your mind as to whether doping is a factor. Endogenous injection of EPO can certainly lead to this, but that's not a benign thing to do. There's an increased risk of thrombotic events for individuals who do that. Exogenous androgens, testosterone, again, the thrombotic risk goes up, and then a lot of the stigmata of exogenous testosterone injection that I think we're familiar with are things to pay attention for. You can dope via blood transfusion, usually auto transfusion. So keep this in the back of your mind. Ask questions, right? Like if you don't ask, they won't tell you. If you do ask, they may not tell you. But if you don't ask, they will not tell you. Um, and then altitude training, small potential role here. At most, you may identify a mild erythrocytosis from an athlete who's been training at altitude, but it takes a while. This is not like I went to Denver for the weekend and went on a few runs, and that's why my red cell count is up. If they're giving you that story, they're probably doping. Um, I think it takes probably a minimum of 3 to 4 weeks to actually see this change at a clinical level, and then it goes away pretty quickly when you return to sea level or something much closer. But potentially this could be something that you see as a result and really perhaps adaptive one of altitude training. Okay, on to bleeding disorders. So a few things that we'll discuss to some extent. So hemophilia, von Willebrand disease, ITP. Again, some fairly basic review here. Hemophilia describes actually a few different inherited clotting factor deficiencies. Classically, hemophilia A, factor 8 deficiency. Hemophilia B is factor 9 deficiency, and C is 11. The first two are X-linked recessive. The third is autosomal recessive, and they're generally characterized in severity by how much factor activity you have. Severe, right, like less than 1% factor activity, essentially no factor activity is where, of course, most of the trouble is. But obviously, from a functional standpoint, more is better. But as you can see, you really don't you don't need to be at 100% to protect against most bleeding, as mild disease really is 5 to 40%. If you have 50% or above, you tend to do just fine. I just put this up here, not that you need the refresher. I know everyone still remembers this. I obviously know every single bit of this inside and out and have it fully memorized. I'm just throwing it up there because you have to in a talk like this. But no, just kind of highlighting where in the coagulation cascade, factor 8, 9, and 11 are operating and why they can lead to sort of similar pathophysiology if you have deficiencies of one of them. So, of course, bleeding risk is elevated at baseline for individuals with hemophilia. Trauma further increases said risk. They tend to get interarticular bleeds, hemarthrosis. That obviously is not good in the short term, very painful, but it's really not good in the long term. Anyone who's taking care of individuals with hemophilia, years and decades down the road, the arthropathy can really be quite devastating. Intramuscular bleeding certainly happens. Intracranial bleeding is not as common, but of course is much more likely to kill you. So we need to be aware of that. And really, you can bleed anywhere. If you don't have factors, it's a problem. Um, you know, Routine care for individuals with hemophilia is like treat them like people because they're people, right? So standard health maintenance recommendations all apply, including like we do want people with hemophilia to exercise. We probably want them to stay away from NSAIDs, really any medicine that can increase bleeding risk, right? It's already tenuous. You don't need to poke the bear. And then factor prophylaxis can be indicated in certain situations, right? So this is just exogenous administration of the factor that they're missing. For people who have severe disease or just bleed a lot, they may be on continuous factor, right? They may, on a scheduled basis, daily or a couple times a week, be using factor. But for folks who have mild or moderate disease who haven't had any serious bleeds, they may only use factor intermittently. Um, Athletic participation is not, strictly speaking, out of the question. And in fact, most people would endorse that it can be done safely with appropriate parameters, right? This is not, just throw you out there with no factor and shoulder pads and play football, but some individualized decision making, I think, is appropriate. These individuals will need to be closely monitored for signs and symptoms of bleeding. And then, particularly if there's any real risk of contact, then probably some prophylactic factor administration prior to each episode of participation is appropriate. But there are lots of studies showing that sports participation can be safe. We generally avoid the collision sports, right? That's I think, fairly common sense. If someone with hemophilia bleeds, you should give them factor. You should preferentially give them the factor that's missing. You should use their own supply if you can, but recombinant factor can be used if that's not available. And then again, some of the basic stuff still applies, right? So you should compress, ice, elevate, etc. And again, low threshold to transport. If they're bleeding and you're not sure it's stopping, get them to somewhere that can take more aggressive care of them if need be. Von Willebrand disease, different, but in some ways related. Again, three different subtypes of sort of different pathophysiology. It can be either a quantitative, like not enough of it, or a qualitative, like your von Willebrand factor doesn't work so great problem. Subtype 3 tends to be quite severe. So where is this operating? So von Willebrand factor is a stabilizer of factor 8. So without von Willebrand factor 8 breaks down much more quickly, and so you functionally have less factor 8, sort of like hemophilia A. But tends to be much more mild than most hemophilia A. People may have easy bruising or heavy menstrual bleeding. I think who should you work up? Like if people endorse a history of lots of bleeding with minor dental work or a ton of nosebleeds or something, certainly if there's a family history, or sometimes thrombocytopenia is identified. Doing a bit of a workup is probably appropriate. This is pretty common in the general population, so it's out there if you look for it. Slightly elevated bleeding risk at baseline. Again, I'm not typically on the level of most individuals with hemophilia. Trauma makes bleeding risk higher. This is true for people without any bleeding disorders as well. Bleeding location with von Willebrand disease, typically a mucocutaneous. So GI bleeding is not common, and musculoskeletal bleeding is actually quite rare in this condition. Although, again, if you have this and you take a knee to your quad, you certainly can get a hematoma. Same deal. The routine care applies. We want people to exercise. Probably stay away from NSAIDs. You can prophylax prior to surgery or a delivery or something like that, and maybe high risk contact sports. DDAVP works for a lot of people. It just releases the stores of von Willebrand's factor that you have, but it doesn't work for type 3 because you don't really have stores. But you can give von Willebrand factor concentrate for people that DDAVP is inappropriate for. Again, athletic participation is usually safe, but the most severe forms you got to be a little more careful with, maybe treating more similar to hemophilia, needs monitoring. Again, DDAVP for minor bleeding, but not for severe, not if it's type 3, or if you've used DDAVP before and it doesn't work, then you don't need to fail every time. And you can use von Willebrand factor concentrate. ITP is not going to be super common in the sports medicine world. Primary is usually autoimmune, and then there are secondary causes as well. petechia, purpura, epistaxis, rarely intracranial bleeding. Platelets by definition are going to be under 100,000. Severity of ITP is really determined by bleeding. Again, this is more mucocutaneous than musculoskeletal or intracranial, and bleeding doesn't actually correlate terribly well with platelet count. And most of the really severe manifestations are with platelet counts under 20,000. It's not entirely predictable. And even you tend to have to get below 10,000 for like spontaneous intracranial bleeding, but under 20,000 is definitely alarm bells. Um, Staying away from NSAIDs. There's not really a lot of data about athletic participation. It's generally felt to be safe at platelets above 50,000, right? Like if a patient is going to have surgery, they usually get transfused up to 50,000 or above. So that's a reasonable sort of expert opinion based. I'm not necessarily evidence based approach. Again, some individualized decision making and monitor for bleeding. If they bleed, you transfuse. Steroids and or IVIG are options as well. I just threw this in briefly. This is not a very complicated slide, but just pancytopenia should always scare you. There are a few benign etiologies, and again, in this kind of student athlete age population, 18 to 22, or depending on the lack of NCAA rules, 18 to 35. But you know that older adolescent, young adult population is definitely an age group that gets leukemia. So if you see pancytopenia, that should bother you, and you should work that up more. Okay, going to jump into some hypercoagulable disorders. We'll go through these pretty briefly. Essentially, we're talking about these six things. Deficiencies of protein C and S. Factor V Leiden gets a lot of press, maybe more than it deserves. Antithrombin deficiency and some, prothrombin gene mutation, antiphospholipid syndrome. Protein C degrades activated factors 8 and 5. And so the absence of it makes you not degrade them, i.e., functionally, you have more of those factors, hence you clot more. Protein S is a cofactor that helps protein C work. And so with no protein S, it's functionally similar to having no protein C. Factor V Leiden encodes some resistance to protein C, so you functionally have more clotting factor 5. Antithrombin inhibits thrombin, and so a deficiency of that, you don't inhibit thrombin, you clot more. Prothrombin gene mutation is a gain of function. You have more thrombin, you clot more. Antiphospholipid syndrome is actually a pretty strong risk factor, lots of prothrombotic effects. Lots of different places that we're working in the cascade here, just felt like I had to continue the theme. We don't typically screen for these. If there's a known family history of VTE and someone is known to have a hereditary thrombophilia, it's probably worth checking to see if your patient, this is not necessarily just applicable to athletes, it's probably worth seeing if your patient has this because they may have increased clot risk. And then moving on to VTE, venous thromboembolism, I'm going to dive into a little bit of some more novel stuff here as well. So long story short, VTE means DVT, PE, or both. It's common in the general population. It happens in athletes. I think we're all pretty familiar with this, but lower extremity, swelling, pain, warmth, erythema. Upper extremity clots happen, and they happen in athletes, right? A Paget-Schroeder, not necessarily too uncommon, particularly in overhead athletes, baseball pitchers, volleyball hitters, etc., swimmers. You can certainly get PE and associated symptoms of dyspnea, chest pain, hemoptysis. Athletes compensate well, right? So I like it's not a terribly uncommon story when an athlete is diagnosed with even something like a saddle PE that they're like, yeah, like I felt bad for about 6 weeks. I was still training, like my times were getting a little worse, and I coughed up a little bit of blood, so I went to the ED. But like they look great, and a pretty serious thing is happening. Don't chalk everything up to a cold. Don't chalk everything up to asthma, particularly if it's not getting better. Again, well-score Perk rule, things you guys know, D-dimer, ultrasound, CT chest with angiogram, maybe a VQ. How do we treat these? Like up front, you start anticoagulation. I'm used to be unfractionated heparin or maybe low molecular weight heparin, but the DOACs, the direct oral anticoagulants, have definitely come more in vogue. Primary treatment is going to consist of 3 to 6 months. Again, it used to be a warfarin or low molecular heparin typically, but now you can use the DOACs for that as well. And then secondary prevention. Some people need it, some people don't. Some people, it's recommended that you're anticoagulated for a long, long time. Specifically, when we talk about these DOACs, you'll see apixaban and rivaroxaban used the most. These are the only two that are indicated for initial monotherapy, meaning you can diagnose someone with, say, a lower extremity DVT, and if you're going to treat them, you can give them apixaban or rivaroxaban and nothing else. If you start them on edoxaban or dabigatran, they have to be bridged with a parenteral agent, so they need several days of low molecular weight heparin. But apixaban, rivaroxaban, you can start them. That's all that they need as the initiation of their treatment. And we talk about risk factors associated with venous thromboembolism and specifically whether we consider them provoked or not. There are multiple things that can provoke a DVT or PE. Things that can be relatively common in the student athlete population: trauma, surgery, OCP use, prolonged air travel. Although, I mean, really that becomes a stronger risk factor, like 8 hour or more type of flights. So really anything within the continental US is probably not a huge risk factor. Um, and if things are not provoked, then we call them unprovoked. It's a catchy little word we use. So, again, as the slide says, an irresponsibly oversimplified management outline for VTE. If you have a provoked, uncomplicated VTE, then you start them on anticoagulation, which these days is usually apixaban or rivaroxaban. There are some reasons why you do something else. You resolve the provoking risk factor, right? If this is female on oral contraceptives, particularly the fourth generations that are particularly thrombogenic, you stop that. You complete the primary treatment because we need to get rid of this clot, so 3 months, at least. But then you can, generally speaking, discontinue anticoagulation because you resolved the provoking risk factor. If you have an unprovoked VTE, so you don't know what to resolve, there's nothing to resolve, or you have a VTE with an unresolvable risk factor, like it's found during your workup that you have a protein S deficiency, and you can't not have a protein S deficiency, then you'll get your initial anticoagulation, you'll get your 3 to 6 months of treatment, but then it'll likely be recommended that you are anticoagulated for an indefinite period of time, which can be a problem for athletes. So you definitely don't interrupt the first 3 to 6 months of anticoagulation. It's not great to be out for 3 months from sport, but again, sports and athletes, like these things do happen, right? 3 month time loss injuries are not that uncommon. You can treat it like that and move on. Exercise can usually be safely resumed during primary treatment. If they've had a PE, then the cardiopulmonary stuff may slow them down. But in terms of like any residual clot that's, in a vein, that vessel wall adhesion and endothelialization is usually pretty well, managed by about the 3 week mark. So you can get back to running and submaximal resistance training probably after about 3 weeks. So you don't have to be, totally sidelined for 3 months. You can be reconditioning. Obviously, if you had, serious cardiopulmonary issues, those need to be resolved as well. So athletes can return to sport once anticoagulation is complete, but the problem is some are recommended for long-term anticoagulation. And historically, that has been seen as incompatible with athletic participation, so athletes are disqualified for their safety. And I think where Dr. Moll, who I referenced earlier, and myself have kind of gotten on the national stage with this is just simply from asking the question: can novel treatments and maybe a novel thought allow athletic participation during that extended anticoagulation period while maintaining an acceptably low risk? And of course, the answer to that is no, that's nuts. Like everyone would just die. It would be an absolute catastrophic mess. No, that'd be a bummer of a talk. So no, so let's think about what we were working with, 30 years ago, 50 years ago. Actually, probably not 50 years ago. I think it was developed in the 70s. That might be 50 years ago. So warfarin was what you were working with if you were using oral anticoagulation, say 30 years ago. It takes a long time to get to a therapeutic level. You can't turn it off very quickly. Even when you're keeping the dose stable, the therapeutic level bounces all around, or at least the patient's blood level is going to bounce all around. It's just difficult to work with, and you're certainly not toggling it on and off. The DOACs are different. They work very quickly. They protect you, some of them almost as soon as you take a dose, and then you can turn them off fairly quickly and you don't have to monitor. And it's this kind of rapid on-off effect, the ability to turn it on and off quickly, that sort of stoked our interest. Because really, if you think about any medication, at some point after you take a dose of it, the plasma drug level concentration, right? First it peaks and then it begins to fall, and it will eventually fall low enough that it's, you have barely any in your system. So at some point it's going to fall to a level where, yeah, there's still some in there, but it's so low that your risk of bleeding is like probably not too elevated. And then of course at some point it clears to a point that it's entirely negligible, right? Eventually it gets out of your system altogether. And at or maybe between these time points, we think you can probably consider athletic participation, and we've published and talked about this to some degree. Um, Again, I know you can't really fully review this at this point in time. This is a complicated topic. It's really not fully within the scope of this talk, so I'm largely just putting this up as a slide that can be available for reference. But this is like, a very simplified algorithm of kind of how we think through and work with patients and their medical staffs, and sometimes their institutions and agents and parents and everybody, to come to some consensus on how we may want to approach anticoagulation in certain athletes. Because one thing that you can do is you can have an athlete take a dose of medicine and then measure their serum, or I'm sorry, their plasma drug levels, at various defined time points, right? So this, for example, it would be someone who took a dose of their medication at 1900 the night before. We had them come to the lab at 8 the next morning, so 13 hours, and we measured a plasma level, and then they came back at 11 and we got another, and they came back at 2 and we got another, they came back at 5, we got another. And we found that their level dipped below 10 nanograms per milliliter, which is a level that we've proposed is perhaps reasonable to consider the safety of athletic participation, including in collision sports like football or ice hockey. If your plasma blood level is below that, it takes this athlete about 17.6 hours to clear below that level. And so then potentially, say for instance, you have a college football player, say he's a lineman, say you got a game Saturday at noon, and he typically takes his apixaban at 7 a.m. and 7 p.m. Theoretically, and we have done this in practice as well, so I guess not theoretically. We know from his PK study on the last slide that he gets below a level of 10 at 17.6 hours, so we'll say 18 for a tiny bit of cushion. So every day that he takes his 7 a.m. dose, if he doesn't take a 7 p.m. dose, then by 1 a.m. the next morning, he would have cleared below this 10 nanogram per milliliter level. And for his 7 p.m. dose, he's going to clear by 1 the next day, again, if he skips his morning dose. And so you can create a schedule of when to and when not to take the medication that is going to give you, a plasma blood level that looks like this. And it will create a little window of relative safety for maybe contact practice on a Tuesday morning, contact practice, or I guess afternoon we're saying here. So on a Tuesday afternoon, contact practice on a Wednesday afternoon, and then I'm clearing it out of your system. It looks like this didn't carry over quite right, but this is meant to, be at a low level for game day on Saturday. So that's kind of the general principle that we're talking about. And that's what we call individualized anticoagulation or individualized intermittent anticoagulation. So, really, that just gets down to patient-centered care, and I would say sort of take-homes of that. In some cases of VTE, extended anticoagulation is recommended, right? If you're able to treat for 3 months and then it's safe to stop, that's not very complicated. But if extended anticoagulation is recommended, then sometimes you actually can continuously anticoagulate an athlete and time those troughs appropriately, still participate in competitive athletics. In some cases, maybe the occasional interruption can be reasonable. And in some cases, it doesn't work, right? This is not something that should be done lightly. This is not something that should be called, the absolute standard of care that everyone should try. Sometimes this is not a good idea, but patient preferences are meaningful. Being told that you can no longer participate in your sport, because you need to be on blood thinners, obviously can be a devastating thing to hear. And sometimes that's not strictly necessary. So we're always going to treat VTE with at least 3 months of uninterrupted anticoagulation, right? We don't do these PK studies or anything, in those first 3 months. Like, you shouldn't interrupt that. Some people may be recommended to continue longer. That can be career threatening, but patient preference matters, and you may or may not actually have to disqualify these athletes because we have some tools that help us. A lot of things have to go right. It's not a given. Great. That was how I was going to wrap. I do have some CAQ questions if we want to go through them, but also can just open it up for questions since it looks like we're down to our last 10 minutes or so.
Yeah, thank you so much, Dr. Berkowitz. That was a great talk. Are there any questions from the audience? I don't see any in the chat right now. If not, Dr. Berkowitz, I'd love to hear a little bit about your perspectives on how you have some of these conversations around like individualized anticoagulation plans, or, just generally speaking, what that conversation goes like in your experience with these athletes who do get this kind of big blow of information and then have to process that and then ultimately go through, kind of options around how they can maximize their sport participation in the future. Any perspectives you have on that would be great.
Yeah, for sure. First thing, block 4 hours in your schedule. Um, no, so I mean, but these are serious things, right? And we see a lot of professional or Olympic level or collegiate or even high level high school who are planning to play in college, and now that there's money in that game, I mean, like these are very impactful moments in these athletes' lives. And so obviously understanding that and being respectful of that, like this is a big deal, right? It is not a death sentence, but it may be the end of your career, which obviously people have a lot of meaning and self-worth sometimes, and sometimes finances tied up in. So I will be very clear. I think really and truly, most of the expert opinion that people come here to get is from my colleague, Dr. Mall. I tell people I'm sort of the sports interpreter, right? Because I'm Dr. Mole is the world-renowned hematologist. I speak both hematology and sports, right? And so I can kind of help uh, navigate the challenges that come up, whether it's a practice schedule or knowing who to communicate with, or how what the actual relative risk of serious contact in various sports is, or what have you. Um, I think we always take a very thorough, we always do the initial evaluation in person. Dr. Mole feels very strongly about that. I think that's a good thing. I take a very detailed history. I say we, again, I'm mostly Dr. Mole. I'm very thorough history, very thorough physical exam. We're usually, of course, by the time we're contacted by someone, the athlete has had some workup, usually a large workup. So we definitely spend a lot of time seeing what's been done, seeing if anything else sort of needs to be done. Have they had their full hypercoagulable workup? So we're able to determine whether they need or don't need long-term anticoagulation, all sorts of things, right? That they've often seen multiple people, and putting all that together. And then it's a very a very direct, honest, open conversation about what this is, what the sort of baseline standard of care is, what the risks are, what we know, what we don't know. And that's actually what takes a long time, right? There's lots of stuff here we don't know. Again, we've been doing this for, again, quite a while now, and we've been working on a manuscript for like 5 years. Maybe we're not actually working on it. We keep wanting to write a manuscript. Um, but at the end of the day, we have a reasonable amount of experience and some, I think, expert opinion that has so far led us largely to positive places. But I think being very clear about the gaps of what we know about risk and safety and what blood level is safe, and all of these things. And we certainly we highly value the athlete's input. We don't blindly do what they say, and we are never trying to instruct the athlete's primary medical team about what they should do, right? We are consultants. If we say, "Oh yeah, totally great to do this. Here's how you juggle the meds," and the team physician is like, "I am not comfortable with that," then they shouldn't do it. Or like if the athlete is like, yeah, I want to do this, but they're like, they don't seem to be taking it seriously, they don't seem to actually understand the risk, they're just like sign my paper so I can tell my team I can play, but we don't actually think it's safe. We're not going to recommend that this individual is a good candidate for this. So it takes a lot of dialogue, it takes a lot of time, but it's like many complex patient care conversations. It's like it's absolutely the stuff that our medical system does not compensate you for at all, right? It's an extensive amount of time. It's really good medicine. You're taking care of people, being their doctor. And the healthcare system values it none, but the patient values it a lot, and it's important work.
Awesome. Thanks very much for that. We have a couple questions that did come in through the chat. Um, One question here, just curious what you would do with an athlete who has mildly elevated iron levels, but simultaneously has a ferritin of less than 20.
Yeah, well, I mean, so like iron, ferritin again is a bit of a limited metric, and depending on sort of where you are in iron depletion, that's not necessarily a totally uncommon pattern. But also, just because the ferritin's low doesn't necessarily mean that your iron's depleted, right? So I think I mean, it's a good question. I think it's a longer conversation, but I think a more comprehensive evaluation of iron status and I mean is what's necessary, and certainly like I feel comfortable, I'm taking charge of a lot of these workups, as many primary care providers who then do primary care sports medicine do. But I think if you're getting to a point in the workup where like the numbers aren't adding up and it's not making sense, it is very reasonable to have them see an actual hematologist and not one who just plays one on the sidelines.
Great. And then another series of questions here. Do you repeat pharmacokinetic studies as an athlete gets older, every 2 or 3 years, for example? And then does the intensity of exercise affect the pharmacokinetics of the DOAC?
Yep. Great questions. We do often, if athletes have been on, some version of individualized anticoagulation for a year or two, recommend repeat studies, because it's known that there is inter-individual variability, right? That you can test people at different times and they will have slightly different, um, outputs. And so, it's not, I mean, yes, you test them as they get older because that's the only way we get. But I think but I'm serially checking over time is certainly a reasonable thing to do. I think again that sort of loops back into like we don't actually know for sure like exactly what is the quote unquote safe threshold. So I think as long as values are staying relatively close to what you've been operating under, then I don't think you necessarily have to change your management much. And even if, say, for instance, you like did the study, found that 18 hours was your clearance point. They played an entire season using that threshold, and then you rechecked after the season, and you were like, shoot, on this test it says 20 hours is what's safe. Well, I mean, that would be concerning, to a degree, and you may want to modify your timings a little bit, but you could also argue that you actually have more empirical data that, like, I'm using that 18-hour threshold was safe for them because they got through a full football season on that. Our plasma cutoff of 10, like maybe that person is fine at 12 and they don't necessarily have to wait for 20 hours, based on their second study, right? So you may have actually, more in vivo data for your specific patient that they can play with an 18-hour interval, kind of regardless of what their blood level is. So it gets complicated. You should take it seriously and think about it. But I think it's an interesting space to work in because we're making like, some suggestions that that again I think are educated, but not necessarily, extremely evidence based. And so if you have actual evidence in your patient of what can be done safely, then I think that's I'm certainly worth factoring in as well. In terms of intensity of exercise, maybe that is really something that we just don't know. I think again, it's entirely reasonable to do these studies like, in the athlete's native state, right? So they can exercise as intensely as they normally would, perhaps in a non-contact practice because they have a high level of anticoagulant in their system while you're doing the study. But I think you can get that, truer data.
Great. And then maybe elevator pitch sort of answer here with our last minute of time. For this last question, it seems like reasonably so. The focus is mainly on not being anticoagulated during athletic participation. Is there any concern for any significant post-participation bleeding when they take their after-practice dose? So, for example, if an athlete were to have a significant injury, traumatic injury to a ligament or otherwise during practice, would they and then need to have to take their scheduled dose in that evening? What are the ramifications of that?
Yeah, definitely something that we think about post-activity check-in. If you had a, like if you took a hit to the head, I would hold your dose that night, right? I mean, I think the short version is it is very likely that the risk of clotting with one or two more missed doses is much lower than the risk of serious bleeding if you've taken, a massive hit to the abdomen and threw up 3 times. Like I would just hold the dose.
Yeah, that all makes very good sense. Well, Dr. Berkowitz, that was great. I think a really unique kind of perspective on things and something that I think is truly cutting edge in a lot of ways with some of these athletes. So thank you for your time. Thanks everybody for joining us, and we're off to a good start here with the fellowship year. If there are any questions, please feel free to stick around. But I think we can go ahead and end the recording, and we'll call it an evening. Thanks, everybody.
Good luck this year.